allow for a couple of seconds. Okay, we are good to go. If you are a founder who has never been ghosted, after a round of flattering words, you're probably as mystical and as rare as unicorn. Most founders do not want sugar-coated praise. They want blunt honesty and tough questions. Yet too often, they are handed empty compliments or vague promises. After all, who wants to risk offending tomorrow's billionaires? The truth is, real feedback does not break founders. It actually forges them. It is the fuel that helps them grow, sharpen their ideas, and ultimately thrive. And that's exactly why EthAum created Rose Sessions. No filter, no fluff, just raw, unvarnished feedback from seasoned experts. Think Shark Tank, but stripped of theatrics and packed with insights. Today, Sardar, founder and CEO of Albert Health, steps into the spotlight. He's here to pitch his solution, tackle tough questions, and hear what a diverse panel have to say about the go-to-market strategies or product roadmap or the solution. Now let's get started with the introductions of our esteemed panelists. I see Sinikka on the screen. If I may request Sinikka to do a quick intro, please. Sinikka.
Hi everyone, pleased to be here. My name is Sinikka Bots and I come from Finland. I would present myself as a health system strategist. My focus areas are value-based healthcare and health system management. My background is in medicine and public health and management studies. And job-wise, I've been working as medical director, chief medical officer, that type of positions in both the public and private sector.
Thank you. Thanks a lot, Sinikka. Really appreciate your time today. Marcus, may I request you to go next, please?
Absolutely. It's a pleasure to meet everybody today. My name is Marcus Wang. I'm sitting here in London. I'm obviously Chinese, but I'm from America. You know, we can tell from my accent. And I'm a former corporate attorney, and I'm also the former co-founder and CEO of Zytogen Global Genetics Institute. We were a molecular genetics company that went live in 2014, and we exited successfully years later. And since then, I'm also a commissioner for the Maryland Healthcare Commission, a regulatory body in the state of Maryland, United States, regulating healthcare. I'm also a partner at Coda Global Ventures, working on market entry expansion, cross-border trade and investment, including a focus on healthcare companies and health tech. And I sit on the board of the University of Maryland School of Medicine. And so very interested in the health tech space and very happy to be here with all of you today.
Thank you. Thanks a lot, Marcus. Appreciate your time today. Sarah, may I request you to go next, please?
Sure. Good morning. My name's Sarah King. I'm also sitting in London. I've spent 25 years in financial services working on strategy, execution, and growth. And my background is in helping organizations scale. So designing go-to-market strategies, launching new products and services, and entering new markets, basically turning those ideas into commercially viable businesses. But I also bring a bit of a clinical lens. I spent 5 years in the NHS after completing a master's in clinical medicine. And I worked both at the Royal Marsden and in primary care, working directly with patients as a clinician, but also as a consultant, working with the senior partners and the consultants in the healthcare organization on projects to improve patient outcomes, streamline pathways, and tackle real-world and operational bottlenecks. So I am delighted to be here, and I've read with a great deal of interest what Albert Health is proposing to do. So excited to be here. Thank you.
Thanks a lot, Sarah. Really appreciate your time. Jonathan, could you please go next?
Hi. Thank you. Morning, everyone. Jonathan Hall. I'm managing partner of Potentia. We have a presence also in London, Cyprus, and Dubai, where I've spent most of the last 25 years. My background is primarily private equity, corporate finance. I mean, a bit generalist overall, but we have done quite a lot in healthcare over the years, buyout of a pharmacy chain in Saudi Arabia, and delisting and take private of a medical device company in Egypt. And then we do quite a lot of similarly sort of market entry into the Middle East for some interesting US and European medtech businesses. Similarly, very interested today, always very impressed, yes, when founders put themselves out there for feedback and constructive criticism. So very interested to learn more.
Thank you. Thanks a lot, Jonathan. Appreciate that. Keith, please.
Hi, everyone. This is Keith here. I'm the CEO of Synthesia, which is my third company, entrepreneur. I'm currently also a senior advisor for a few family officers in Singapore here. So I built a medical device company before. I also worked in Merck for about 8 years before I came out and start my own business. So previously it's through medical device company, and right now helping medical device company from overseas to enter Singapore and also Southeast Asia market. So
fantastic. Thanks a lot, Keith. Appreciate your time. Again, thanks to all the panelists for being with us today. As I requested earlier, please do not hold back, be direct, be sharp, and turn up the heat a bit. Now it's Sardar's turn. Sardar, please introduce yourself and you can share your screen, walk us through Albert Health solution, and then we can start taking questions. Sardar, please.
Sure. Thank you so much. I'm also very excited. Looking forward to your honest, direct feedbacks. Today, by the way, I'm with our medical director, Dr. Zeynep. We're going to answer your questions together after the presentation. Let me share my screen.
So Sardar said that, hey, I don't want to get roasted alone, so I'll bring Dr. Zeynep with me so that we both can get roasted. Sardar, please go ahead.
Thank you. Yeah. I'm, by the way, as a background, I'm an engineer. Started my career in Turkey in pharmaceutical sector. Then I worked for the Siemens, German company. Then we left the Siemens with my co-founders, and I founded Albert Health. Albert Health is an evidence-based multi-chronic disease management platform to increase medication adherence of people with chronic diseases. So far, we have raised $3 million from international investors such as Techstars, Telefonica, and the biggest Turkish holdings. And we made $3 million revenue with collaboration with big healthcare players such as Novo Nordisk, Pfizer, Sanofi, Abbott, Roche, NHS, the big insurance like Bupa, Taunia. Now, actively 20,000 people following their medication, following their treatment with Albert Health. And we are active in Turkey, in the UK, and Saudi Arabia. The problem we are solving is medication non-adherence in chronic disease management. Just in the MENA region, Middle East and North Africa region, 70% of the deaths are caused by non-communicable diseases. And 30% of the adults are obese. There are 70 million adults in the MENA region live with diabetes. And just in diabetes, the spending is $33 billion. It's a huge burden for the world, but for the Middle East and North Africa, here is the capital of the metabolic diseases. What we are doing, Albert, is an evidence-based multi-chronic disease management platform. We are helping patients with medication and symptom tracking so they can increase their medication adherence. They can measurement and device integrations. We are connected with Roche AcuCheck glucometers, Xiaomi Smart Scales, Apple Health, Google Fit, their smartphones, their smartwatches. Patients can watch videos, read articles with the app, and they can connect with their doctors, psychologists, dietitians easily. And doctors have a dashboard to track patients' data, and they can send messages, reminders to the patients. This is what we do. But the important part is how we do. We have an AI-based voice assistant trained by our medical team and specialized a patient-specific LLM model, so we can answer the questions of the patients continuously. We are gamifying the patient experience with leaderboards, engagement scores, and we are personalizing the experience according to patient medical history and demographics. So each patient gets different notifications, different tasks. And, we are leveraging the AI in every step of patient's journey. First, of course, we are collecting the data from different sources like electronic health record system, wearables, patient reports outcomes, symptom checkers, physician notes, in-app activity, claims, etc. And then our medical team are labeling them and augmenting them Then we are creating risk scores of the diseases and creating patient subgroups. This is helping us to create guidance based on individual risk profiles and create a patient-specific LLM model. So they don't need to talk the public LLM models, because public LLM models don't know your health, don't know your disease, what is your routine, what is your current health status. Of course, chronic disease management is a huge area, huge domain. We know we need to focus. So our biggest focus is metabolic diseases. Why metabolic diseases? Because it has high prevalence. It's biggest market. And it needs behavioral change, continuous monitoring, and it's very personalized. Why oncology as a second focus? Unfortunately, it's the fastest growing area. Care is very complex. Doctor needs data for better decisions, and it requires long-term monitoring and caregiver involvement. How we are making money? We are charging monthly license fee to pharmaceutical companies, insurance companies, and healthcare providers. Why? Because out-of-pocket spending in chronic disease management is low in our region. Why pharma companies are paying us? Because we are generating a real-world data for them. Why insurance companies are paying? Because we are reducing their claims, their healthcare spending. Why healthcare companies are? Because we are creating revenue streams, new revenue streams for their patients and increasing the loyalty of their patients. You may ask, is it working? Yes, it's working. We conduct a randomized controlled trial with a healthcare provider in Turkey, and we proved we are reducing A1C level by 1.07. It's the highest evidence level in our in the digital health space. You may ask, is it validated? Yes, Albert is now CE certified. That just the last month we got a CE certification, and we are recognized as a Class 2A software as a medical device. In our region, in Turkey, is the first time. In our region, one of the first ones, therapeutic mobile application has obtained a CE mark. This is the team. As a founders, we have the Siemens background. I also have an IQVIA background. We have a leadership team who has background from the clinics and the biggest technology company from the Turkey. I already mentioned our investors. Now we are raising another convertible round before our Series A, because we want to go to Series A with the break-even. We are very well aware of how the investment thesis changed in last years. And we want to complete our, not complete, let's say, that we want to strengthen our strategic expansion into the Middle East and North Africa, specifically the GCC. And we want to set up a virtual clinic to complement our personalized AI-driven coaching with live clinician support. We are raising 750,000 K. Actually, we already got the 700K. We are in the very last part of our convertible note round. This is Albert. I will be happy to answer your questions. And with Zeynep.
So that was a very short and sweet presentation from Sardar. We can open for questions. Keith, I know you have to leave, so do you want to start first? Yeah, please.
Yeah, thank you so much for the presentation. It looks great. Just want to understand a bit more on the go-to-market strategy part, which is the adoption part. I can see that you have three of them, which is a pharmaceutical, insurance company, and healthcare company. But what exactly is your go-to-market strategy? Are you going to talk to the doctor adopt this one, and then encourage all the patients to adopt this, which will require patient data? Or you are going to a digital department of the hospital? So what exactly is your go-to-market strategy here? Or you're going to the insurance company, which one is?
Yes, actually, we are running all the B2B sales in the two main chain. One, the direct sales, which are our team. The second one, we are utilizing our channel partners like IQVIA and the big the consulting companies like McKinsey, PwC, and IQVIA. after we obtain the B2B customer, of course, the biggest thing is the reaching the real users, the patients, as you say. And then the model is changing in every channel. For example, for pharmaceutical companies, we are utilizing their Salesforce team. They have a huge sales team. They are visiting doctors every day. So their sales team are promoting us to the doctors. And then doctors are recommending Albert to their patients. It's like prescribing digital therapeutics. In the insurance side is very straightforward because there is no regulative barriers. So they know who has diabetes in their among their policy holders, and they are directly promoting us. And hospitals also, the doctors are prescribing Albert, let's say, with the medicine, and they're extending their value proposition to the home, and they see what happened at home between two appointments. This is how we acquire the B2B customers and how we reach the end user, the patients.
Yeah, thank you so much. So I got one more question on it. Is there any connection or collaboration with the government?
In Turkey, we have, let me start with Turkey, our operational base. In Turkey, we have like a mature digital health ecosystem. The government already legislated the main, the requirements of the digital health. We have a national health data exchange platform. So we are connected with that platform, and we are reporting which patients made a telehealth service with which doctors. We are all reporting this data to the government. So each citizen can see the reports in the main national health exchange platform. But it's just a one-way reporting, the kind of. And in this round, the Turkey Development Bank, which is government supported, the venture capital firm, are becoming our shareholder. It's a great news because, in a healthcare, which is very government heavy sector, it's good to get the support of the government. And we are also sorry, they are not. It doesn't count as a government support or connection, but of course we are also complying with the legislation which government publish in the UK, in the Turkey, and in the Dubai.
Fantastic. Thanks a lot. I see a couple of hands are raised. Yes, Sinikka, if I may request you to go next, please.
Okay, yes, thank you for the presentation. I've had the pleasure of meeting with Albert Health before, and I find it very interesting, promising as well. However, there are some concerns as well that I would like to
Sinikka, could you please speak a bit louder?
Okay, can you hear me now?
Yep, better, much better.
Okay, yes. So to me, your model seems very insurance-based, and it seems that you are targeting pharma-supported markets, and my concern is related to the public health system viewpoint, where comorbidity and equity and principles like that are key principles. We aim for integrated pathways, etc., etc. And to me, the concern is that you are supporting a fragmented way of approaching chronic disease management. So I would like you to say something about that. In other words, I'm interested in how you see your product avoiding fragmentation, and also how does your current evidence support the public health system viewpoint, if you get my point.
Thank you for the question. I definitely agree. In the digital health, let me tell the story from my perspective. In the digital health, the monetization is the hardest part. Finding the payer is very hard. And in our region, healthcare companies are not well funded. like in the US. For example, I know some companies in the US, which is their valuation is like a 20x of ours, and our revenues are same because they are with the well-funded the organizations have a luxury to just focus and create their impact nationwide. And there were very good examples also in the UK in the past, like a Babylon. It doesn't work at the end, but making company-wide, the country-wide the applications. But as an entrepreneur, to create revenue streams in the beginning, to fund the future, and to create attraction, we need to make partnerships in these fragmented markets and show our capabilities to investors, to customers, to governments. And so, for example, now we are in discussion with the Turkish government, we are in discussion with the DHA, Department of Health in Abu Dhabi, and saying, use us as a company-wide application. Let's integrate our disease management programs to your national health mobile application, because we know that if we do that, we will create a real impact, as you mentioned. We are not also happy with this fragmentation, but this is the natural pathway of a startup in an emerging country. This is my point of view.
Thank you, Cesar. I see there are questions from Marcus, Sarah, and Jonathan as well. Let's go ahead with Marcus first. Marcus, please.
Thank you very much. So first of all, great presentation, great product. I looked into your decks earlier, and it looks really great. I mean, we have a couple questions though, and one of the questions actually just following on what Sinikka just asked you and your response. And you're talking about the challenge that you're trying to expand across these multiple smaller markets, right? They've all got distinct regulatory requirements. It's a challenge. Folks in America are valued 20 times more the same revenue. Why are you not focusing your resources on the larger digital therapeutics market in the United States right now?
Yeah, thank you for the question. Of course, we are choosing the markets with we created a framework to how to choose the marketing. We believe team to market fit. What is our capabilities? What is our network? How we can leverage our network and create the opportunities. And after this team to market analysis, we chose the Turkey and the Middle East area. And we also believe the market is there's a big unmet needs in chronic disease management here. Because why? In the US, it started like 15 years ago, the big chronic disease management companies like Omada Health just made the IPO, for example, or Dario Health. They are founded in 14 years ago, 12 years ago. And when we started this business, we saw that, yes, there are many mature ones in the US, there are few mature in Europe, but there's a big opportunity here. So we tried to use this opportunity, and we saw that our team to market, the formula is also applying here. It doesn't mean we will not go US at all, but after we tap this market and also create more revenue, more impact, and it will bring us the funding. Yes, we want to also go in the US in the long term.
Real quick, not to jump to anyone else, but that being said, how do you protect your market from these competitors who are larger, who might scale faster? What's to stop Apple Health or someone else from coming in? What is your sustainable competitive advantage? Is it being a first mover?
We are lucky that healthcare is a very local business. You need to really understand the local patient needs, local healthcare systems, local data, the money, the flows. So, and you need to create a local environment. Even now, we see some competitors here. For example, the Huma, the biggest UK digital health company. I think I can say that. They're coming here, but they're using local distributors because they also know that it requires a big resources to come and being active here. So we believe our execution, the speed and the focus into the local area. But it doesn't mean of course, we will not create a big the other differentiation. We are really creating medical evidences to show, yeah, we made clinical trial in this region, and it's as good as they in their the medical evidences, and it's local because their medical evidences is outside the region. So to have a cultural adaptation, to have know-how of the local market, to have local evidences, there are big advantages for them. They are also, by the way, not just our competitors, also potential exit players.
May I request Sarah to go next, please?
Sure. Thank you. Thank you for your presentation. I had a couple of questions, if I may. I wanted to dig into your user group and actually the value of your offering. So I heard you say you have about 500,000 users across many diseases, but you've obviously got that one validated pathway with your 3-month random control trial around diabetes. So I'm interested to know how many of your users of that 500,000 are in that validated pathway. And then the second part of my question is thinking about patients with diabetes. Often they don't just have that. I think, as Sinikka and some of the other panelists have said, often it's one of a number of comorbidities. At least in the UK, and I'm pretty sure everywhere else, that's the kind of place where patients can't titrate their own medications. They need to go and see their healthcare provider. So is your application, is Albert Health more just reminders and like kind of lifestyle nudges? What actual clinical value does Albert provide? Are you managing the disease or are you just tracking it? If it's tracking, what are you giving the doctors and the hospitals that they don't already have?
Thank you for the question. I think I can tell this better than Zeynep. Let me give the word to them.
Okay.
Yes, thank you for the question, Sarah. For the first example, for the first question, I would say that like our platform is divided into many clinical programs. So we run not only this clinical trial, we have many clinical trials. Some of them are sponsored by Albert Health, and some of them are supported by the pharmaceutical companies. So our diabetes is one of the focuses we are leaning on at the moment. And what you've seen is a 3-month clinical trial where we have done this clinical trial in a government-supported hospital with actually patients who are not that self-aware of the disease itself. I have practiced medicine for 6 years with chronic diseases, and I've seen that if the patients are most aware of the disease, they can manage their diseases properly. In these hospitals, actually, patients are not paying specific money to the doctor or neither to the medication itself. So all the medications on the market are serving to these patients. The only problem actually is even we have the insulin, the actual insulin that is produced from our body is, that can be injected through a pen. But if the patients are not adherent to the treatment, they are not educated enough, the treatment outcomes are, the patient outcomes are getting worse. So in our clinical trial, we've just pushed the patient to adjust to the treatment plan. It's not only medication adherence, but the treatment adherence, we prefer to say, because it's not only taking the medication correctly, but also, adhering to the homeworks that the doctors is giving to the patient. So if I saw a patient in the clinic, I gave a lot of homeworks to these patients, and after they walk out of the clinic, I'm not able to seeing them, and I'm not able to monitor them if they are doing them correctly. So what Albert do is, as a value proposition, they track these patients, they monitor what's going on at home, and actually making some kind of pushes to these patients to adjust to the treatments. And once the next visit comes, we invite the patient via Albert Health to the actual clinics. We demonstrate to the doctor in a structured way what's wrong at home, like are they adhering to the treatment, the medication, the lifestyle, the diet. They can take pictures of the food they're eating and they can show this to their doctor or their dietitian, so we can spot what's wrong, not only in Albert Health, but we can show the results to the doctor so they can understand, okay, this insulin is not enough for you. Okay, you are not doing the exact lifestyle changes that you should have done. So actually for chronic diseases, even without the visit timing, we can monitor what's going on in patient's life and we can adjust it. It's not only tracking, but adjusting the homeworks in a way that the patient can answer and adhere to. So that's the value proposition we provide not only for the patients, but also for the doctors. And for the clinical trials, you've seen the one that we have created for diabetes, but we also have other clinical trials. For example, one for children with growth hormone deficiency. They are applying a kind of an injection once a week, and it's super hard to forget mixing the days for the medication timing. So we reminded these patients not only the timing of the medication, but also tracking the side effects if they forget or if they apply a lot. So we monitor them, we educate them via Albert Health, and we have demonstrated that actually it's like a comparison study. We measured the first baseline adherence scores of these patients, and then we changed the groups, and then we monitor the baselines again. And what you see, their adherence rates are quite increased after Albert Health involved in their lives. So we have many clinical trials, but I'm not able to say that this is the whole Albert population and this is the major impact we put. Yeah,
that's very helpful. I guess the number I was missing is of your 500,000 users, how many are diabetics? So just to understand that you've given me a really good answer in terms of what the value proposition you see. I guess I'm going to be cynical, having seen it from the other side. The kind of patient that downloads an app is the good patient, the already compliant patient. And I think a lot of people, they want to be better at managing their health, but I'd be intrigued to know, of the number, if you can give me that, which have diabetes on your platform, how many stay beyond 90 days themselves? Because diabetes is a lifelong disease. So just really trying to understand that business model of longevity, because that, as you know, is critical in chronic disease management.
Yeah, great. Actually, that's a huge problem. And
it's a really tricky one. It's a really, really tricky one. Download the app, they start, and then they stop. And it's interesting you said about the growth hormone, because patients have a mother of a child who has a growth deficiency, they are so motivated. They will love your app. They really want to be involved because that's the mum doing it. But the average person with diabetes, it's the good patients who will already be taking the medicine will be loving your app, but the naughty ones, the ones who are not coherent, whatever with it, then concordant with it, then they're not going to be doing it. So that would be very interesting to understand how that's working for you.
Yes, that's a super common bias. Sorry, Sardar, I'll give you the word in a minute.
Yes.
But that's why the diabetes clinical trial we designed, the inclusion criteria was all the patients, including to the clinical trial, should be tech-savvy, able to use a mobile app, because in the region that we are applying this clinical trial, the socio-educational levels are a bit low. So we decided to choose the ones as, the physicians who are sitting in the walk-in clinic decided the ones who are able to use the phone. So actually, when we compare the demographics of the two groups, actually there was no difference. So basically they are at the same level in terms of social demographics and a clinical way. So even the ones who are using the app, probably if they are, if they are not dropping from the clinical trial, probably they are good students, in terms of diabetes management. But in another study we have done, what we have monitoring was the engagement of these patients in one cohort. So the ones who are not willing to participate, who are not able to apply to the, we are losing it in the clinic, we involve these patients to the program, then we monitor how engaged they are. And then what we see is that the ones who are engaging a lot achieved more adherence, increased adherence scores in the app. The one we have done with Novo Nordisk, we were in a super standardized way monitor their adherence rates to applying to the insulins. So what we've seen that if they are more engaged, they achieve better scores in terms of adherence. And as an indirect result, they maintain better blood glucose levels. So there are two completely different clinical trials, but what we are focusing on as patient profiles were totally different as well. Yeah, Serdar, you were saying, sorry.
Yeah, I will answer some the number related answers. Let me share my screen. Yeah, you can see my screen, right?
Yeah.
Yeah, I want to show you some retention numbers. As you say, the retention is the number one metric for us. And it really depends on the disease management program. For example, we have a tube feeding program. There are some patients who can't eat something orally. They are using tubes, like we call it enteral nutrition,
Yes.
like they are using the tube for feeding. And in this case, the patient's caregiver using our mobile application and asking our LLM to like, how can I install the tube? The tube is stuck. How can I solve it? How can I clean the tube? Or how can I get the water, send the water from the tube? It's a very hard condition. We started with the Abbott in Turkey. Then we started the clinical trial with NHS in the UK for this purpose. And the aim is to reducing the hospital readmission. In this program, our retention is 95% because they really need the solution. It's 0% cosmetic, But for example, we have also we had a hypertension program in the past, and the retention was 50% because
I was going to say that the diabetes and hypertension, in my experience, those patients are the trickiest.
Yeah, for diabetes, really the seriousness level is really changing. There are type 1 diabetes, there are insulin users,
Yeah, I'm talking type 2. Type 1, I think, are a different cohort.
Exactly.
Yeah,
type 1 and the insulin user type 2 are using our mobile application very well, and they are getting the benefit. We know that we are not a wellness company. We are not a nice to have solution for them. We are targeting the people who really need us. Okay. This is of course increasing our numbers, and then we are also very happy to serve them. They need solution. There are hundreds of wellness apps in the market, but there are few cancer apps. There are very few hemophilia app or growth hormone deficiency app to help a mother, And for diabetes, also let me answer your question. Now there are 20,000 people actively following their treatment with Albert. 500,000 the patients is the population we are serving, because there are insurance companies. They have 200,000 people. It's open to them as a Albert. They are downloading Albert, even they are not patients. They are checking, they are recording the water reminder. They are recording their vitamins as a the wellness purposes. Yes, we are serving also them, because Albert has also the 100% match with a wellness app in terms of feature base. What our focus is chronic disease management, and in the chronic disease management, a number are like that. Thank you so much.
Thank you.
I think Jonathan has been waiting for quite some time now. Jonathan, please go ahead.
Yeah, thank you. I guess some of my questions, very much overlap with what people have been saying. But I think my question would be, looking at it, more from an investor perspective, really is where does the business go? The value proposition, fine, look, I get it, and but the reality is, there are dozens of similar apps, and the value proposition is the same. People are better informed. They take their medicines on time. The doctor gets the information. This is the value proposition of digital disease management. The question is why why should it be you guys that come out the other side? But I think I'm interested to learn a bit more. In the deck you talk about 3 landmark contracts in the Middle East, and I'm interested to know how your plan is. And I think I would propose that a strategy would be more to be dominating the Middle East region. I mean, and not contemplating going to the US and not contemplating going to Europe. Where you've seen Middle Eastern regional companies have very successful exits is where they have dominated the market. Careem being sold to Uber, some of the food delivery apps getting sold to the European and US majors. It's dominating the market from a customer's perspective and having the contracts, the customers, the data, and all of that in place. So I would suggest your better strategy is to be focused on embedding yourself as deeply as possible, like say signing up with the government health agencies, the hospital groups, all of that, and not really contemplating going outside of the region. So I wonder, who are these contracts with, and where do you think that goes?
Thank you so much for your feedback and the question also. As you said, there are great examples in the region, and we believe in the healthcare the same will happen, because GCC is there's a huge unmet need, and they are really investing in this area. The government is really investing in the digital health. You already are working in the Dubai, I know, and the Pure Health, Mubadala, and 42
exactly.
initiative.
But these guys, why would these guys just not go straight to someone like Huma or Apple and give them $100 million to do a GCC diabetes program?
They are doing it, by the way. It's not.
Yeah,
they are already.
Sure.
They are already looking for the big competitors. But it's all about It's all about the showing them. We know the market. We are here. As a founder, I moved to Dubai. I was in Istanbul, and in the last year, I moved to Dubai to manage the expansion, because they want to see the CEO here. They want to work with you. You know better than me. They want to co-create in the GCC. They really want flexible solutions and like a VIP customer services. And we are trying to give what they need. So we are tailoring it to the culture. Culturally, we are adapting it. Is it culturally? We are adapting
but
it.
Is it really that different? I mean, is it that different?
Exactly.
Ordering food on Talabat is no different from ordering in Deliveroo in the UK. I mean, I know medical is slightly different, but I mean, what is culturally different about the GCC in terms of diabetes management?
Yeah, like in the GCC, for example, I'm now living in the UAE, and the Deliveroo, I think, is number 5 delivery company in the Dubai.
Because they were late. They were late to market, not because they're any different.
Sorry?
That's because they were late to the market, not because they're any different.
Yeah, I mean, the locals are beating them, no?
Because they were first and they got in there, which is exactly my point. I mean, I wouldn't say they're any better, I wouldn't say Talabat is more culturally, appropriate than Deliveroo. Just they were there first.
But for example, the Careem is more connected with the local environment. So when you subscribe to Careem, you are opening you can order the home cleaning, you can order the spa, you can order taxi, but in the Deliveroo, just food. So they are not connected with the local environment. For example, in Dubai, for example, you are using Just Life, right? You used Just Life before?
I don't use that, but yeah.
Okay. The biggest service company in Dubai is founded by Turkish people who come to here as an entrepreneur and connected with the Careem and create a great success stories. We believe the localization. We did it, by the way, before in Pawunia. Pawunia, the biggest insurance company in the region, the biggest government owned Saudi company. They opened a tender, and I saw many companies from the Europe and the US that are billing. We won it. Why we won? Because we committed a Saudi employee in the Riyadh, and we supported them locally. We is a flexible infrastructure. We serve them in a way they want. Now, of course, it's challenging. It's making things harder in terms of productization, but unfortunately, it is the the nature of the region.
Sure, look, I think I'm sure that applies, everywhere. It's not just a Middle East phenomenon to be localized. I mean, I think, but I mean, that's why. I mean, I would recommend your strategy is digging in the region and not contemplating heading to the US anytime soon.
Thank you,
Thanks
Jonathan,
so much.
for that.
Anyway, yeah. Good
Probably
luck.
let's take one more round of questions quickly, and then I would request Sardar to ask questions to the experts and get some feedback or insights from the experts on the go-to-market strategy, on the product roadmap, on the solution. Sinikka, did you have a question?
Yes, I have a few comments actually. I wanted to continue from what I said earlier, from the concern that this is product-based instead of a patient or a product-centered instead of a patient-centered product. And the reason why I'm saying this is that the way I understand it, that you mainly focus on medication non-adherence, which is what you said in the beginning. And then I'm hearing some discrepancy between that and your very wide strategic view. You have a long list of chronic diseases, the etiology of which is very different, and the treatment of which is also very different. And you are basically claiming to cover the whole clinical ecosystem in the management, even prevention of them. And my third point would be related to clinical evidence. I'm still kind of, after everything that has been said, I'm left with the feeling that that's kind of not very convincing. You don't have many randomized clinical trials supporting your product, and also the ongoing studies. I'm left with the feeling that there's a risk for bias in them, since you are the main sponsor in most of them, or the pharma industry, which brings me back to my first point, which was product centeredness and not patient centeredness.
Yeah, thank you so much. These are also points we are trying to improve. We know that we are a little bit verticalized. It is in our domain, recently I was reading an article about why there is no very big healthcare company dominating all the cases in all the therapeutic areas, because in healthcare there are thousands of use cases which is independent to each other. So it's pretty hard to scale between therapeutic areas. That's why after we made clinical trials, we felt like we are not focused. We made, the hemophilia, we made growth hormone deficiency, MS, oncology, metabolic diseases. We tried many, many things. Then we said, okay, we need to choose one and focus. Then we started to focus on the metabolic diseases. We got CE mark, we got the clinical trial, and we are not investing a lot in other areas clinical trials, because we saw that if we do 20 clinical trials in 15 different therapeutic areas, it will not work, and it will take too much time, and we will not be focused. So then now we are more focused than before. We are more focusing on the metabolic diseases, and still, yes, our aim is to creating an ecosystem around the metabolic diseases. Why metabolic disease? We already talked about it. It's more suitable for digital health. Let's say, for the clinical trial perspective, even pharmaceutical companies are being criticized as you don't have enough the clinical evidence after they invest in the billions of dollars. We know that we are in a very early stage. As you said, we are really believing we are very early stage, but we are also believing we are ahead of others because this area is very in a very early stage. We are doing our best. There is no, Zeynep is an internal medicine specialist. For an early stage company like us to hire an internal medicine specialist full time, it's not easy. You can believe me. It's a very resource heavy, let's say. And we are investing in this area to create more and more. But some of them are not. Some of them are a little bit biased. The evidence level is not very high. But we are believing in, according to our the stage of our company and the region. Yes, we are ahead of our peers, but we committed to do it better, and we committed to make more clinical trials and show Albert a digital health solution can really create impacts on people's lives.
Thank you. Thank you, Sardar. I think Sarah has a question. So let's take that last question and we'll move on from there.
Yeah. Oh, yes, I appreciate we want to have a couple of minutes for you to ask questions. It was just to touch on what Sinikka and you just discussing. I was thinking about your what does your sustainable monetization look like? And I think you've been very open and honest about the fact that your value proposition is pretty broad at the moment, and that you see value in actually, getting that adherence. That said, when you think about how medicine is actually delivered, there are specialists. You go to see cardiologists for your heart, you go and see the respiratory doctor for your lungs. It is like that. And I wonder whether you're trying to be something to everybody, and perhaps where you would have more long-term value is actually deciding whether you are focusing on one or two of the conditions, or take a step back and say that you're a generalist, and this is a nudging and tracking program, and that you are partnering with somebody, and the adherent patients, and neither is a bad idea, but they're just different. And at the moment, I feel a little bit that the offering's a little bit conflicted, that you're trying to do a lot for a lot of diseases, and actually it's perhaps do less for more, or actually do the kind of deeper vertical for fewer conditions. And that might just move the needle a little bit on making this a real sustainable recurring revenue opportunity.
Thank you so much. It's a great question. Actually, yes, the medicine is all about experimenting, and we experimented a lot. Now it's time to settle and to focus on the metabolic diseases. We wanna own the journey of the metabolic diseases, and we're gonna invest in more, as I say, the virtual clinic. It was not just a buzzy title. We wanna hire more doctors to give the services, and we want we imagine a world like we need to give every service a diabetic patients the needs. Then we can monetize it like Omada did. We can create a B2C diabetes program. Everyone can subscribe it, and insurance companies can reimburse it, not co-create. Now we are co-creating diabetes program with them. But after we got enough evidences, after we create the virtual clinic and connect it with a medication delivery, whole ecosystem, then you can say that, okay, now I am owner of the journey and reimburse me. So insurance companies, the reimburse, even in the future, the value-based care can be good alternative for us in the future. If we can manage to own all the journey with all these the stakeholders.
Thank you.
Thank you. Thanks a lot, Sarah. And Sardar, Dr. Zainab, as I mentioned to you earlier, you are sitting in front of experts from different parts of the world who understand different aspects of the business. If you have any questions in your mind that, hey, I want to get their opinion or their guidance on go-to-market strategy or on product roadmap, please feel free to ask those questions and get the insights from the experts.
Yeah, I have one question. There is one big dilemma in companies like us. We are a software company, and a startup always want to stay as a software company. Normally, we don't want to deep into the operational level. But we also see that, we also witness that if we if we connect with third-party healthcare providers, and if when patient needs a doctor, if we connect them to the third-party healthcare providers, even digitally via our telehealth infrastructure, the system is broken. Like the connection is broken. Why? Because imagine a third-party healthcare provider, doctor, is connecting to telehealth and saying, okay, what is your complaint? Tell me what's your symptoms. They don't care the data in the Albert Health. They don't follow the journey. We have the data, the patients are using Albert for 2 years. Then I am connecting the patient via our telehealth infrastructure to the third-party doctor, and they don't care all the data. They are just making a regular consultation. So we witnessed that some of the companies like us, they are hiring their own doctors and creating the virtual clinics, but it is increasing the operational burden. It is then, it's affecting your scalability, but it's also really improving your the patient experience. And therefore, you can make a value-based care or the other things thanks to this integration. You can make you can go beyond with the third party, the healthcare provider support. It's a little bit tricky. We talked about a lot, and we talked with the doctors. We talked about our experiences, and we decided to create the virtual clinic with a 2-layer. First layer, like a coaching layer. Some of the doctors, and nurses, we will position them as a coach. They will track daily with the help of the AI and to motivate the patients, check their data. And the second layer will be on-demand doctor support. We will continue to get it from the third party. Because if we create all the virtual clinics in-house, then it will be so operational heavy. We are trying to create a hybrid model, like a 2-layer model, half of it inside, half of it outside. What do you think about this? And how do you find the solution?
Anybody? Yep.
I'll take that.
Yep. Go ahead, please.
Well, Serdar, first of all, great question. I mean, I would step back for a second. You're talking about the different features you want to have, the different partnerships you want to have. So I would say step back for a second, look at it from the perspective of the end game. And that the end game should determine what features you're going to add, what partnerships you're going to forge. And it's going back to some of the questions you answered earlier that Jonathan was asking you. I don't think, the more I'm listening to this, you have a great company, great tech, and great team, obviously, but I don't know that the protective regional moat that you're citing all the time of focusing on the GCC, I don't know if that's enough to protect you and insulate you from the competitive pressures from external competitors. I feel like a well-funded competitor, like the ones in your deck, they could easily, breach that moat through acquisition, through a roll-up strategy, and immediately they're going to have access to the local data, the local relationship, and the local infrastructure that you cited as being a protective moat. I think they can breach that. So the question is, to your earlier point, what is the end game? Is it the liquidity event? Is it the acquisition? And in that case, if that's the goal, then do you want to maybe think about scaling rapidly and making yourself attractive for acquisition? And then it fits in the framework of, does this partnership that you want to do, or do these features you want to add, do they make you more attractive to potential acquirers? And does it do it in a quick enough time scale to get there?
Thank you, Marcus. That's a very quick and Sinikka, please go ahead.
Yes, I wanted to continue from what Marcus just said. I think you should, that would be my recommendation for you, is that you focus on the value that your product produces and to whom, that you answer the question for yourself, who is the one that you want to produce value to? Is it the pharma industry, insurance companies, or is it a more population-based view? And then another point that I wanted to raise is that I think you should look into how you integrate your product to the existing care paths. And that would be a means for you, I think, to protect yourself against these competitors that Marcus mentioned.
Thank you. Sarah, please.
Yes, I'm gonna I guess echo what Marcus and Sinikka are saying, is actually think about where you're going to see yourself in kind of 5 years' time. I think you're absolutely right. It's two different and competing kind of almost like an imperfect business model. If you can't be everything to everybody. I really like the idea of thinking about which way you want to go. And so if it's going to be for the general population, they're tracking, they're owning their journey, they might be able to be refunded by their insurance company, things like that. That is nice, but it's a completely different model. I would probably advise quite strongly, if exiting in the next few years is your plan, to go the other way and hire a lot of health professionals to support your own virtual clinic. I think, like Sinikka has just suggested, actually partnering with other clinics would be really valuable. So like in the UK, it's different. You obviously have the NHS and you have private health. Obviously in the Middle East and Turkey, I think it is a different model. But smaller clinics who wouldn't have the bandwidth or the skill to have that AI platform and the digital platform that you have, if you partnered with a group or even a few clinics, they could use your tool, and you could obviously, depend on how you negotiate it, you have access to their client data, and actually that's a really nice model in terms of recurring revenue, and for eventual exit, you have a model that's going to consistently grow, because there's going to always be, I think about putting yourself in the shoes of when you're a patient. It's really, really useful to be able to access your doctor online and be able to do that. And if they give me a really nice app as well, even better. Do you see what I mean? So that would be a quite exciting way to go, I think.
And not necessarily just small clinics, I think. You get a lot of the, I'm sure you must be having conversations, some of the larger hospital groups across the Middle East, have their own tech platforms. I know I've spoken to other, people, whether it's sort of mental health related apps and things that they've talked about, being integrated. I guess the question is whether you're happy to be a bit white labeled in some of these instances, within some of these broader platforms for these groups, getting very embedded there for the longer term, then I think is, does set you up well for, an exit. I think, that perhaps is, the conclusion then here. I think sort of getting as deeply embedded and as you can in the ecosystem is very valuable.
Thank you. All the panelists again, Sarah, Jonathan, Sinikka, Marcus, Keith, who had to leave. You all have been extremely fantastic with your feedback, questions, guidance. Really, really, really appreciate it. Again, Serdar, what you did today is extremely, extremely commendable. You invited criticism for yourself on a live stream public forum like this and responded to it very, very positively with a smile on your face. It requires a lot of courage. It requires the right kind of positive attitude. Hats off to you for your guts and positivity. It's definitely inspiring. Again, hope this session will bring a new energy, new ideas, and new growth trajectory for Albert Health to take it forward. Again, thanks everybody for hosting this today with us. Really appreciate your time, and I hope we can reconnect. We can explore how we can work with each other, support each other's initiatives, and create a win-win for everybody. Yeah. Thank you. Thank you very much.
Good luck, guys.
Thank you all very much. Great to meet you all.
Good luck.
Thanks
Thank you so much. Thank you all for your comments.